about the drug therapy of peptic ulcer. In my previous episode, we have discussed the drugs that neutralize gastric acid secretion or antacids, and this has been discussed in details. In this part of the video lecture, we will be discussing the rest of the drugs that are useful for the treatment of peptic ulcer. The first category, drugs that reduce gastric acid secretion. These can be subclassified as 1. Anticholinergics, and the drugs are propantholene, oxyphenonium, pyranzepine and telenzepine. The H2 receptor antagonists such as cimetidine, ranitidine, famotidine, nizatidine, loxatidine, roxatidine. Third, proton pump inhibitors such as omeprazole, lansoprazole, pantoprazole, rabeprazole and esomeprazole. Prostaglandin analogs such as misoprostol, enprostol, rioprostol. The next category is mucosal protective drugs, and the drugs are sucralfate and colloidal bismuth subcitrate. The next category is ulcer healing drugs, and this includes carbinoxolone sodium. Then lastly we have the anti-H. pylori drugs, which includes antibiotics such as amoxicillin, clarithromycin, metronidazole, tetracycline, a proton pump inhibitor or H2 receptor antagonist, and bismuth subsalicylate. So this is the list of drugs that are useful for the treatment of peptic ulcer. To start off with the drugs that are useful for the treatment of peptic ulcer, these include anticholinergic agents. Prior to the introduction of H2 receptor antagonists and proton pump inhibitors, antimuscarinic agents such as propantholene and oxyphenonium were mainly used for the treatment of peptic ulcer. These are quaternary compounds and do not cross the blood-brain barrier. Therefore, the central side effects are less. Because these are non-selective muscarinic receptor blockers, they cause anticholinergic side effects such as dry mouth, constipation, urinary retention, photophobia or blurring vision. They are not useful for the treatment of gastric ulcer as they prolong the gastric emptying time, and this exposes the ulcer crater to the gastric acid mixed with food, thus leading to aggravation of the condition. So these drugs are not useful for the treatment of gastric ulcer. Also, they are not useful for the treatment of reflux esophagitis because of the delay in gastric emptying time and relaxation of the lower esophageal sphincter tone. There is regurgitation of the gastric contents into the esophagus, leading to exacerbation of reflux esophagitis. Therefore, they are not useful for the treatment of gastroesophageal reflux disease. To overcome these drawbacks, selective muscarinic receptor blockers were developed, and these drugs are pyranzepine and telenzepine. Pyranzepine and telenzepine can be used for the treatment of gastroesophageal reflux disease, gastroduodenal ulcers, stress ulcers and so on. The next category is H2 receptor antagonists. The drugs are cimetidine, ranitidine, famotidine, nizatidine, loxatidine and roxatidine. How do the H2 receptor antagonists act? These drugs act by blocking the H2 receptors of the gastric parietal cells. So they block the receptors and prevent the actions of histamine released from the enterochromaffin-like cells and prevent the actions of histamine, and thus are useful for the treatment of peptic ulcer. So what are the uses of H2 receptor antagonists? They are useful for the treatment of gastroesophageal reflux disease, gastric ulcers and duodenal ulcers, stress ulcers that occur in the context of profound illness and trauma that requires intensive care. Also, these drugs are useful for the treatment of NSAID-induced ulcers. They can be used for the treatment of Zollinger-Ellison syndrome. What is Zollinger-Ellison syndrome? This syndrome is due to pancreatic and duodenal gastrinomas and is associated with excessive secretion of gastrin, leading to excessive hydrochloric acid secretion and hyperchlorohydria, causing mucosal erosions and ulcerations. So these drugs, H2 receptor antagonists, can be used for the treatment of ZES or Zollinger-Ellison syndrome. So what are the side effects of H2 receptor antagonists? Cimetidine, the prototypic drug, can cross the blood-brain barrier and can cause central side effects such as changes in the mental status. So cimetidine, when given intravenously, can cause changes in the mental status. However, this side effect is not observed with other H2 receptor blockers because they do not cross the blood-brain barrier. So this is the drawback of cimetidine. The second drawback of cimetidine is that it can cause endocrinal side effects. So these endocrinal side effects occur due to inhibition of binding of dihydrotestosterone to androgen receptors, causing impotence in males. Also due to inhibition of estradiol metabolism and increased prolactin release, there can be gynecomastia in males and galactorrhea in females. Thus, the endocrinal side effects are gynecomastia in males, galactorrhea in females, impotence in males. These endocrinal side effects are more observed with cimetidine. Also, cimetidine is a potent inhibitor of cytochrome P450 enzyme. Due to inhibition of cytochrome P450, drugs that are metabolized by cytochrome P450 are not sufficiently metabolized. This leads to accumulation of drugs in the circulation, leading to toxicity and side effects. Thus, cimetidine can give rise to drug-drug interactions which is not observed with the other H2 receptor blockers. So, the newer H2 receptor blockers such as famotidine, nizatidine, loxacidine have lesser side effects and a better safety profile compared to cimetidine because they can avoid the drawbacks of cimetidine such as the changes in the mental status, the endocrinal side effects, the drug-drug interactions. So all these side effects are more observed with cimetidine compared to the newer H2 receptor blockers. The next category is proton pump inhibitors. Proton pump inhibitors are superior to H2 receptor antagonists in suppressing gastric acid secretion. They are considered to be acid labile, which means that they are easily destroyed by gastric acid juice. Therefore, they are available as enteric coated formulations. The enteric coating dissolves in the intestine, releasing the drug in the intestine and is available for action. Proton pump inhibitors are available for oral use and also for parenteral use. How do the proton pump inhibitors act? All proton pump inhibitors are prodrugs. The prodrug gets converted into sulfonamide, which is the active form in the parietal cell. Sulfonamide covalently binds with the cysteine residue of hydrogen potassium ATPase pump and forms disulfide bond. Due to the presence of covalent binding with the hydrogen potassium ATPase pump, the pump molecules are irreversibly inactivated. Due to irreversible inactivation of the proton pump, there is prolonged acid suppression for about 24 to 48 hours because the new synthesis of pump molecule takes about 24 hours. Therefore, although the proton pump inhibitors have a very short half-life of 1 to 2 hours, the acid suppression, the duration of acid suppression lasts for about 24 to 48 hours because the new synthesis of pump molecule takes about 24 to 48 hours. The next point, food decreases the bioavailability of proton pump inhibitor, but also to be kept in mind that if administered in empty stomach, the proton pump would be in an inactive state. So this would decrease the therapeutic efficacy of proton pump inhibitor. Therefore, these drugs are taken 30 to 40 minutes before breakfast so that the concentration of the drug gradually increases and the peak serum concentration of the drug matches with the maximum activity of the proton pump which occurs in presence of food. Therefore, proton pump inhibitors are taken 30 to 45 minutes before breakfast. With respect to the clinical users, proton pump inhibitors are very good drugs for the treatment of H. pylori associated gastric ulcers and duodenal ulcers. They are useful for the treatment of gastroesophageal reflux disease, the ulcers associated with NSAID use or non-steroidal anti-inflammatory drug use, the stress ulcers or gastric bleeding resulting from stress ulcers, and Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is associated with pancreatic and duodenal gastrinomas, which is accompanied by excessive gastrin secretion causing excessive hydrochloric acid secretion leading to mucosal erosions and ulcers. Next, what are the drawbacks of proton pump inhibitors? Proton pump inhibitors decrease vitamin B12 absorption, causing vitamin B12 deficiency on long-term use. They also decrease the calcium absorption, causing osteoporosis on prolonged use. The use of proton pump inhibitors in long term can increase the risk of gastric infections because, as we know, that gastric acid serves as a barrier against bacterial infections. So, by suppressing the gastric acid secretion, there is increased risk of enteric infections, there is colonization of bacterial strains, and the conversion of ingested nitrates to carcinogens. Therefore, increased risk of bacterial infections is a possibility with long-term use of proton pump inhibitors. Long-term use of proton pump inhibitors can also increase the risk of carcinomas. This is because of prolonged suppression of gastric acid. This leads to increased release of gastrin. Gastrin is a trophic hormone and causes hyperplasia of enterochromatin-like cells to carcinoid tumors and increases the risk of carcinomas. Proton pump inhibitors also increase the risk of chronic inflammation of the gastric body. The next group is prostaglandin analogues. The drugs are misoprostol, enprostol, and rioprostol. Prostaglandin analogues, in particular, prostaglandin E2, enhances the mucosal defense mechanisms. They increase the mucus secretion, bicarbonate secretion, and increase mucosal blood flow. They also decrease the gastric acid secretion by decreasing the cyclic AMP formation and decreasing the gastrin release. So they decrease the gastric acid secretion and also helps in mucosal defense mechanism. They are useful in healing of gastric and duodenal ulcers associated with non-steroidal anti-inflammatory drugs and those that are associated with stress. However, prostaglandin analogues have a very short half-life of 25 to 30 minutes. Therefore, it requires multiple dosing. Also, there are certain side effects such as colicky abdominal pain, increased secretion of fluid and electrolytes into the intestine causing diarrhea, and therefore the prostaglandin analogues are less widely used compared to proton pump inhibitors, which are equally effective and better tolerated than prostaglandin analogues. The next group is mucosal protective drugs, and the drugs included in this category are sucralfate and colloidal bismuth subcitrate. We have learned that acid-induced damage and pepsin-induced hydrolysis of mucosal protein contributes to mucosal erosions and ulcerations, and this can be inhibited by sulfated polysaccharides. So sucralfate is an aluminum salt of sulfated sucrose that causes polymerization in acidic pH. So in acidic pH, there is polymerization or cross-linking of the molecules, and the sticky gel-like polymer adheres to the ulcer crater or the ulcer base for 6 hours. Therefore, sucralfate is administered 4 times daily so as to protect the mucosal membrane against gastric acid damage. Also, it is to be remembered that since polymerization of sucralfate occurs in acidic pH, antacid should not be administered along with sucralfate because antacids increase the gastric pH and this would inhibit the polymerization process and decrease the effectiveness of sucralfate. Sucralfate, because of its unique mechanism of action, is useful in the treatment of various other conditions that are associated with chronic inflammation of the mucosa. It has a good safety profile, and the most common side effect of sucralfate is constipation. It can bind to phosphate in the intestine, causing hypophosphatemia. Therefore, sucralfate is contraindicated in patients with chronic kidney disease. The next mucosal protective drug is colloidal bismuth subcitrate. So it forms a protective coating on the ulcer base and provides protection against damage by gastric acid and prevents mucosal erosions and ulcerations. It also has activity against H. pylori. It dislodges the H. pylori organism from the gastric mucosa and has antimicrobial activity against H. pylori. This is helpful for treating H. pylori associated infections of gastric ulcerations and duodenal ulcerations. So colloidal bismuth subsalicylate or citrate has good safety profile, except that it can cause blackening of stool or darkening of tongue. The next category is anti-H. pylori drugs. So why is anti-H. pylori treatment necessary? The colonization of duodenal mucosa occurs by H. pylori bacteria. 90% of duodenal ulcers, 60 to 70% of gastric ulcer and 50% of non-ulcer dyspepsia are H. pylori positive individuals. Therefore, H. pylori eradication is considered to be a standard care in the management of peptic ulcer. How does H. pylori cause damage to the gastroduodenal mucosa? H. pylori is a gram-negative rod and has a unique ability to survive in the gastric medium. In acidic medium, it survives and it has a urease activity, that is, it converts urea into ammonia. So the presence of ammonia or the release of ammonia increases the gastric pH and forms a protective covering over the bacterium, which helps the bacterium to survive in the acidic medium. Because ammonia is released, which increases the gastric pH, the negative feedback mechanism is disturbed and there is increased release of gastrin, which causes increased secretion of gastric acid, causing hyperchlorhydria, contributing to mucosal erosions and ulcerations. So excessive release of gastric acid further enhances the mucosal damage and increases the risk of ulcer formation. In addition, H. pylori releases proteases and lipases. Proteases cause degradation of the mucosal proteins and increases the risk of mucosal erosions and ulcerations. And lipases damage the epithelial cell membrane and cause mucosal ulcerations. So, by the release of enzymes such as proteases and lipases, there is increased mucosal inflammation, ulcerations and erosions. Therefore, H. pylori, by possessing urease activity and increasing the release of enzymes, proteases, lipases, and also causing an increase in the gastrin release, enhances the risk of peptic ulcers and erosions. Therefore, eradication of H. pylori is necessary in the management of peptic ulcers. So now let's talk about anti-H. pylori therapy. So there are two types of therapy, triple therapy and quadruple therapy. The triple therapy includes 3 drugs and this is administered for a period of 14 days. The quadruple therapy includes 4 drugs and is continued for a period of 14 days. The triple therapy includes a combination of antibiotics, that is amoxicillin and clarithromycin, and with the addition of an acid suppression therapy, for example, a proton pump inhibitor or H2 receptor antagonist. So 2 antibiotics which can include amoxicillin and clarithromycin and a proton pump inhibitor or an H2 receptor antagonist. Now, with respect to use of antibiotics, metronidazole and tetracycline can be considered as alternative antibiotics in place of amoxicillin or clarithromycin. Next, we move on to quadruple therapy, which includes 4 drugs. So here there is an addition of a mucosal protective drug, that is bismuth subsalicylate, in addition to the combination of two antibiotics and an acid suppressive therapy, that is a proton pump inhibitor or H2 receptor antagonist. So in triple therapy, there are two drugs, combination of two antibiotics and a proton pump inhibitor, and in quadruple therapy, it's a combination of two antibiotics, a proton pump inhibitor, that is an acid suppressive therapy, and a mucosal protective drug, which is bismuth subsalicylate. Next, what are the factors that influence the selection of anti-H. pylori drugs? 1. Single antibiotic regimen is ineffective in causing complete cure from H. pylori infection and can lead to microbial resistance. So to avoid microbial resistance, combination of antibiotics is used. This increases the effectiveness of anti-H. pylori regimen. Secondly, acid suppressive therapy such as proton pump inhibitors or H2 receptor blocker enhances the effectiveness of the antibiotic regimen against H. pylori. Third, a 14-day treatment is more effective and better than shorter duration of treatment. Lastly, 3 or 4 drug anti-H. pylori regimen taken several times during the day can lead to poor compliance to therapy. So this causes inconvenience to the patient as the drugs have to be taken several times during the day and for a period of 14 days. So to improve compliance, packaging of the daily doses into one convenient unit is necessary and is available, and this improves patient compliance and adherence to therapy. This brings us to the end of the topic. These are my references. Thanks for watching. Please like, subscribe and share.